Hemodynamic collapse, it doesn't give you the luxury of second guessing. When a patient crashes, their survival depends entirely on your ability to instantly profile their perfusion and congestion status. So we're skipping the pleasantries today and jumping strictly into the physiological stakes of heart failure and shock. This explainer is going to rigorously deconstruct the exact mechanisms, the discrete management steps, and, frankly, the lethal traps that define high-stakes cardiovascular emergencies. Okay, let's establish our physiological baseline. Clinical shock is fundamentally defined by two primary axes: perfusion and congestion. Perfusion, well, that's driven by the cardiac index. If the CI is strictly greater than 2.2 liters per minute per square meter, the patient is well perfused. We call this warm. But if that CI drops below 2.2, you're looking at severe tissue hypoperfusion. Think altered mentation, cool extremities. That is cold. Then we have the congestion axis, which is dictated by pulmonary capillary wedge pressure, or PCW. Keep it strictly below 18 millimeters of mercury, and the patient is dry. But push that PCW above 18, that drives fluid straight into the alveoli, causing pulmonary edema and those audible crackles. That's what we call wet. And this matrix perfectly maps how those two variables intersect. It's the classic 2x2 hemodynamic grid. By mapping our perfusion axis, warm versus cold, against our congestion axis, dry versus wet, we can strictly categorize any patient's shock profile. Now, a healthy patient is warm and dry, but pathological states, they push patients right into those other three quadrants. In a clinical setting, your absolute mandate is to use this high-contrast framework to instantly differentiate volume overload from hypoperfusion. Let's move to Profile 2, the preload catastrophe, presenting as warm and wet. So, in this warm and wet profile, which is your classic acute decompensated heart failure, the patient's cardiac index is actually holding up above 2.2. They're well perfused, but their PCWP is massively elevated above 18. Basically, they're overwhelmed by systemic volume that's actively backing up right into the pulmonary circulation. Your absolute medical mandate here is strictly decreasing preload without compromising systemic perfusion. You've got to administer an IV loop diuretic, like furosemide, immediately. This relieves that congestion without tanking their forward cardiac output. Now, if they've got normal or severely elevated blood pressure concurrently, you have to immediately add an IV vasodiuretic, like nitroglycerin. This actively pulls blood in the venous system, literally pulling it out of the pulmonary vasculature to provide rapid symptomatic relief. But what happens when forward flow completely fails? We enter Profile 4, the lethal quadrant, presenting as cold and wet. In this lethal quadrant, the failing left ventricle drops the cardiac index strictly below 2.2, making them cold, while blood severely backs up, pushing that PCWP above 18, making them wet. It's cardiogenic shock. And the absolute most dangerous error you can make here is falling for the diuretic trap. Pushing a heavy dose of furosemide in a hypotensive, poorly perfused patient, that's totally contraindicated. You will crash whatever preload they have left and trigger fatal hemodynamic collapse. Instead, you have to follow the inotropic mandate. You need to administer an inodilator, like dobutamine for beta-1 agonism or milrinone for PDD3 inhibition. The goal is to aggressively increase myocardial contractility and stroke volume. You absolutely must restore forward flow before safe diuresis is even an option. To really lock this down, we need to delineate between two incredibly similar presentations: cold and wet versus cold and dry. Both present with poor perfusion, hypotension, and cold extremities. The variance relies solely on central venous pressures and congestion. While our cold and wet patient is in cardiogenic shock, which requires those positive inotropes we just talked about, the cold and dry patient is actually in hypovolemic shock. That could be from overdiuresis in a heart failure patient or acute hemorrhage. They're going to present with flat neck veins and clear lungs. This specific profile strictly mandates gentle IV fluid resuscitation to restore the circulating volume. Given an inotrope to an empty heart, yeah, that's disastrous. All right, moving into the master case, testing deep hemodynamic integration. Okay, here is your patient profile blueprint. We have a 70-year-old male with a history of ischemic cardiomyopathy arriving in the ED. He is severely dyspneic and confused. On exam, you're seeing mottled cool extremities, a critically low blood pressure of exactly 85/55 millimeters of mercury, and bilateral pulmonary crackles. Look very closely at the diagnostic traps embedded in this presentation. The pulmonary crackles heavily tempt you toward immediate diuresis, right? Meanwhile, that profound hypotension heavily tempts the use of pure vasopressors just to spike the blood pressure. Based strictly on this clinical presentation, What is the single most appropriate initial pharmacologic intervention? Here are your exactly 5 distinct, highly competitive answer choices simulating advanced board-level conditions. Is it IV furosemide, IV nitroglycerin, IV isotonic fluids, IV dobutamine, or IV norepinephrine? Take a second and think about it. You strictly have to map this patient to the correct Forrester quadrant to survive this case. Let's break down the physiological logic exhaustively. The patient is confused, he's got cool mottled extremities, and he's hypotensive, so he's cold. He also has severe dyspnea and bilateral crackles, so he's wet. We are clearly in profile 4, cardiogenic shock. Now, if you selected IV furosemide or IV nitrates, you fell right into the diuretic trap. You just crashed his remaining preload and likely caused cardiac arrest. What about IV isotonic fluids? Well, if you picked that, you misidentified him as hypovolemic and massively worsened his acute pulmonary edema. And IV norepinephrine, you attempted to fix the blood pressure, but you fatally spiked his afterload. Remember, a failing left ventricle simply cannot pump against increased systemic resistance. That's going to further decrease cardiac output and cause severe digital ischemia. Which leaves us with the only correct intervention, IV dobutamine. As an inotrope, it directly increases myocardial contractility, raises the cardiac index, improves systemic perfusion, and brilliantly restores the forward flow that's absolutely necessary to eventually allow for safe diuresis. And this brings us to our ultimate takeaway. Relying on superficial symptoms, like thinking crackles automatically equals diuretics or low blood pressure always equals fluids, that will inevitably lead to critical failures in complex scenarios. By understanding the raw underlying mechanisms of the heart, the strict interplay between preload, afterload, contractility, and congestion, you essentially render yourself immune to these clinical traps. Master the physiology, and you won't just master your exams, you'll master the resuscitation bay. So the next time a patient's pressures are crashing right in front of you, will you fall for the superficial trap, or will you know exactly how to fix the pump?